Good morning, dear friends. And once again, we are going to go back to the skull base and continue the subject of anatomy of the skull base by talking about the skull base triangles and the skull base approaches. As you all know, it's a very difficult topic to include in one lecture. And the skull base approaches, there are books and chapters in books about skull base approaches. So I can't mention all the details of the approaches and the tips and tricks in these approaches, but we are going to screen these approaches and say something or some hints about each approach as much as we can. First, we'll talk about the skull base triangles. When you talk about the triangles, they are mostly triangles around the cavernous region. So these triangles represent points of entrance of cranial nerves in the skull base, cavernous sinus, carotid artery, and it's the base for certain approaches. And they are mostly the triangles between cranial nerves in the middle fossa, from the second to the sixth nerve, from the optic to the abducent, and the dural entrance. And there are triangles more important than others. The most important is the anteromedial triangle, clinoidal triangle, or Dolenz triangle, mentioned or discovered by Professor Dolenz in the 80s, late 80s. And the posteromedial triangle of Kawase and the posterolateral triangle of Glascox. Actually, you can have 10 triangles of the skull base. Some of them are very famous. We have the anteromedial triangle, so you should have the anterolateral triangle or Mullen's triangle. And you have the lateral triangle, then posteromedial, posterolateral, infromedial, infrolateral. And we are left with PPO in addition, Parkinson, paramedian, and oculomotor triangle. So we have 10, anteromedial, anterolateral, posteromedial, posterolateral, infromedial, infrolateral, lateral, Parkinson, paramedian, and oculomotor. The anteromedial triangle, as we said, is the most famous triangle. It is between the optic nerve, the oculomotor nerve, and the dural entrance, or it is the dural entrance of the optic and oculomotor, and it is exposed after drilling the anterior clinoid, and it exposes part of the carotid artery which is extradural, as the carotid artery on its way to the intracranial cavity, it passes with an extradural segment between the proximal and distal rings. So this is a very famous picture of anatomy by Professor Dolenz. Here we can see the left side, the optic nerve, carotid, and superior orbital fissure. Oculomotor nerve is in the superior orbital fissure, and you remove the anterior clinoid, and you find here the extracranial carotid artery coming in the anterior loop from the cavernous sinus to the intracranial cavity, and in front of it you will find the mucosa of the sphenoid sinus. So, and if you remember when we are talking about the endoscopic approaches from below, the lateral optic carotid recess between the optic nerve and the carotid. And we said that the recess is a hole inside the anterior clinoid. So here, removing an anterior clinoid, optic nerve, oculomotor and superior orbital fissure, you get what we call anteromedial triangle, Dolenz triangle, clinoidal triangle, and this is the proximal ring, and this is the distal ring. You can revise this with the chapter of the cavernous sinus. Anterolateral triangle is more lateral to what we have between V1 and V2. V1 superior orbital fissure, V2 foramen rotundum. So If we look also, this is the left side. This is the ophthalmic, maxillary, and mandibular division between V1 and V2, between the frontal, the maxillary, and the branches of the trigeminal nerve. We get the anterolateral triangle. Then we have Parkinson's triangle. Professor Dwight Parkinson in the 60s tried to enter the cavernous sinus in a space between the trochlear, you can say between the trochlear and oculomotor from one side and V1 from the other side. So this is V1, this is also the left side, and here is the carotid, here is the oculomotor nerve with the trochlear nerve at one side and the V1. This is Parkinson's triangle. In the depths, of course, is the abducent, the sixth nerve. Another triangle, it is the paramedian or the supratrochlear. This one is considered the infratrochlear because it is below the trochlear nerve. The supratrochlear or the paramedial, if there is a potential space, you know that the oculomotor nerve comes from below upwards in the lateral wall of cavernous sinus, and the trochlear nerve comes from above downwards, crossing each other on their way to superior orbital fissure. If you separate the space between the trochlear and the oculomotor, you get a space which we call the paramedian triangle or the supratrochlear triangle. It's not that important. And the lateral triangle, we said the anterolateral triangle between V1 and V2, ophthalmic and maxillary. So the lateral triangle is between V2 and V3. Here on the way to the foramen rotundum, and here is on the way to the foramen ovale. This triangle, V2, V3, is the lateral triangle. Posteromedial triangle of Kawasi is very important. We have a nerve, greater superficial petrosal nerve, from the geniculate ganglion, branch of the facial, for lacrimation, and the Gasserian ganglion and superior petrosal sinus. Actually, it's not a triangle, it's like a trapezoid shape. It has four corners, but we call it the Kawasi triangle. It is present on the medial petrous bone till the petrous apex, from where the trigeminal root crosses the petrous bone to the what is medial to it, till the apex. And it is a good approach to reach lesions related to the lateral mid-pons. For instance, ICA aneurysm or meningiomas in this region, or epidermoid. So we have here the trigeminal root, and as you see at the petrous, the furrow on the petrous above surface is, you will find it on the petrous bone, except medially, where the vein is above the trigeminal root, because we cannot leave a vein compressed below the trigeminal root. So if you have a bony skull, you will find on the upper surface petrous furrow, petrous groove, and then the medial part you don't find it because crossing of the trigemin. Between this trigeminal root, trigeminal Gasserian ganglion, and between the superior petrosal sinus, and medial to the greater superficial petrosal nerve, which we talked about, you will find a space. This space, if you drill it, you can reach the middle fossa and reach the posterior fossa from the middle fossa. What is this bone? This bone is a thin bone in the petrous apex. This bone is present on the petrous bone. But what is lateral to the greater superficial petrosal nerve is present in the middle fossa. So this is a very important point. Kawasi is in the medial anterior border of the petrous bone. Thin bone, the medial part of the petrous bone is very thin, unlike when you go laterally. Why? Because when you go laterally, it's the jewelry box. What is the jewel? The jewel is the cochlea. But the medial part of the petrous bone is formed of thin bone because nothing important is inside it. So Professor Kawasi decided to drill this part to reach the posterior fossa lateral aspect at the midpons from the middle fossa. And here again, if you have the greater superficial petrosal nerve, and as we said, it is anterior, it is present in the anterior petrous bone, not in the middle fossa. What is medial to the greater superficial petrosal nerve? What is medial to the Gasserian ganglion? What is medial part of the petrous apex? Look here, very thin bone, and you drill this bone. But when you go lateral to the greater superficial petrosal nerve, there is a triangle called Glasscock's triangle to expose the carotid, as you will see now. So this is in the medial anterior petrous bone. It is the part of the petrous bone medial to the Gasserian ganglion, medial to the trigeminal, and medial to the greater superficial petrosal nerve, or posterior to it if you want, and what is lateral is Glasscock's triangle. So you take this thin bone from the middle fossa to reach the posterior fossa. And the Glasscock's triangle is between the greater superficial petrosal nerve, as we said, V3, and the hiatus of the nerve to the foramen ovale. Again, this is the trigeminal root, this is the Gasserian ganglion, and this is the mandibular division, and what is lateral or anterior to the greater superficial petrosal nerve, between the greater superficial petrosal nerve, between the, here Gasserian ganglion ended, between V3 and the junction between V3 and the hiatus of the greater superficial petrosal nerve. What is the hiatus? The point where it pierces the petrous bone on its way to the pterygoid canal. You know, this will join the deep petrosal, forming the Vidian nerve. So this is Kawasi in the anterior medial petrous bone. It is the part of the petrous bone medial to the crossing of the trigeminal. It is thin bone, it is empty bone, and you can take it very easily. Glasscock's triangle is lateral to the greater superficial petrosal nerve. It is present in the floor of the middle fossa, here in the anterior surface of the petrous bone. Very important. And you join the greater superficial petrosal nerve with the mandibular division of the trigeminal, and you connect the foramen ovale with the hiatus. You get Glasscock's triangle. What is the importance of Glasscock's triangle? It exposes the carotid in the base of the skull in case you need proximal control. When you work on cavernous region, you don't have to open the neck to get it. You can put a temporary clip on the carotid here in Glasscock's triangle. So Kawasi and Glasscock. Oculomotor trigone, oculomotor triangle, is a very important triangle present between three ligaments: anterior petroclinoid ligament, posterior petroclinoid ligament, and the interclinoid ligament. And of course, the central part of the oculomotor triangle passes the oculomotor nerve, and the trochlear nerve passes in the lateral angle of the triangle at the point of crossing of the free and attached edge of the tent. So here, the petrous bone, we are on the right side. This is the diaphragmacelli, diaphragmatic hiatus, anterior clinoid, posterior clinoid. Between the two clinoids, we have the interclinoid ligament. Between the petrous and anterior clinoid, anterior petroclinoid ligament or fold. Between the petrous and the posterior clinoid, posterior petroclinoid ligament. Here, the oculomotor nerve passes, and in the lateral angle of this triangle passes the trochlear nerve between the free edge and the attached edge of the tent, intersection trochlear here. Again, you can see this is the dorsopsilly, left side, clivus. This is the trigeminal root, portio major, portio minor. This is the abducent nerve, and this is the oculomotor nerve, posterior petroclinoid ligament, anterior petroclinoid ligament, and interclinoid. The oculomotor nerve in the center, trochlear in the lateral angle. Inframedial triangle is between the trochlear and the abducent. So if we have here the edge of the tent, you will have here the trochlear, and below you have the abducent. It is inferior. Inframedial, infralateral between the trochlear, abducent, and petrous apex. So, trochlear, abducent, petrous apex, infralateral, and trochlear and abducent. And posterior clinoid is here, inframedial and infralateral. So we said between the trochlear nerve, this is the abducent, the petrous apex, and the trochlear nerve. This is inframedial, this is infralateral. And there is also a triangle, we can sometimes forget talking about it, but it's not in the middle fossa, it is in the posterior fossa, called Troutman's triangle. It is a triangle between the sigmoid, the superior petrosal sinus, and the semicircular canals. And this triangle is of utmost importance in the posterior petrosal approach, what we call the pre-sigmoid subtemporal approach. So as we said, between the sigmoid sinus is pre-sigmoid. It is anterior to the sigmoid sinus. And here is part of the skull from inside, from the left side, transverse sinus, sigmoid sinus, passing jugular bulb, jugular foramen. Here is the superior petrosal sinus, in front of the sigmoid, below the superior petrosal sinus, and the semicircular canals here. There is a triangle called Troutman's triangle. What is the importance? If you go from the mastoid to this region, you can enter the posterior fossa. And when you do the pre-sigmoid subtemporal approach, pre-sigmoid is in Troutman's triangle. So here again, it is a triangle in front of the sigmoid sinus, below the superior petrosal sinus. So superiorly superior petrosal, posteriorly is the sigmoid, and anteriorly is the semicircular canal. So this is Troutman's triangle. Again, it is pre-sigmoid between the petrosal, superior petrosal, sigmoid, and semicircular canals. This is Troutman's triangle. Suboccipital triangle, sometimes it is considered as one of the triangles of the neck. Some people consider it one of the triangles of the skull base. So you can mention it. We did mention it before in the anatomy of the vertebral artery, but it is present in the back of the neck, and it is the deepest region of the back of the neck of the muscles, underneath the trapezius, splenius capitis, semispinalis capitis. So trapezius is one layer, splenius and semispinalis second layer. The third layer is the boundaries of the suboccipital triangle, with two oblique muscles, superior inferior oblique and the rectus capitis posterior major, rectifying, extending the head, and major because medial to it there is the minor, as you will see. Roof is formed of the semispinalis capitis because it is superficial to it, and the floor contains the posterior atlanto-occipital membrane. If you remember the chapter we talked about the cranio-vertebral junction, posterior atlanto-occipital membrane, and the posterior arch of the atlas, and the contents, most important is the vertebral artery and the vertebral plexus around the vertebral artery, and the suboccipital nerve C1, which is a sensory nerve. C1 has no motor. So we took the trapezius, we took the splenius capitis, and we have the third layer here, two oblique muscles related to the transverse process of C1. Superior is the superior oblique, inferior is the inferior oblique, and medially this is a muscle called the rectus capitis posterior major, because this is rectus capitis posterior minor. So these are the boundaries, and it is present in a deep layer below the trapezius, below the splenius capitis, and you can say that the splenius capitis is forming the roof. And here you can see the content: vertebral artery, vertebral venous plexus or occipital plexus, and the atlanto-occipital membrane. It is a pathway in the far lateral approach to reach cases when you want craniocervical tumors like foramen magnum meningiomas. And you see also in the roof there is a nerve which is the dorsal ramus of C1. So foramen, the transverse process of the atlas, superior oblique, inferior oblique, rectus capitis, posterior, major. Minor is unrelated to the triangle. Skull-based approaches, as we said, will try to give as much information as we can, but we cannot give all the details. You have to read more about these approaches, but we'll try to be as much as we can useful for you and simplifying matters, especially in some approaches which are perplexing for many people. So when we talk about the skull-based approaches, the easiest way is to identify where are we going, what are we going to approach. Is it the anterior fossa? Is it between the anterior and middle fossa? Is it the middle fossa? Is it between the middle and posterior fossa? Or is it the posterior fossa? So when we approach the anterior fossa, we talk about the subfrontal approach. The lateral subfrontal approach is a very, very important approach. The bifrontal approach and endoscopic extended transsphenoidal, you can go through the endoscope and reach the olfactory groove, for instance, meningioma. You can take it from the anterior fossa, tuberculum celli meningioma, planum meningioma, and others. So these are the approaches to the anterior fossa. Or some approaches are exposing the anterior and the middle fossa. The most famous and most important, and which was used for the first time by Professor Yaşargil, late Professor Yaşargil. We lost him a few days ago, and it is very famous, as you all know. But we have also the mini-pterional approach, and we have the cranio-orbozygomatic approach, COZ, and the mini cranio-orbozygomatic approach, mini COZ. The middle fossa, we have the anterior subtemporal, we have the anterior petrosal Kawasi, we have the posterior subtemporal, and we have the endoscopic transpterygoid. So in the middle fossa, we have pure approaches to the middle fossa and combined approach between the middle and posterior fossa, which is the famous posterior petrosal or the pre-sigmoid subtemporal approach, the one used frequently by Professor Al-Mufti, Sam Al-Mufti, Sam. And approaches to the posterior fossa, of course you all know about it: midline tilovelar, supracerebellar infratentorial, paramedian, lateral retrosigmoid, which is for the cerebellopontine angle region, and the craniocervical, the far lateral approach. So we'll start by the anterior fossa, and here you can see many of the approaches of the anterior fossa. We have the unilateral subfrontal approach. It can reach up to the midline, and you can have the eyebrow supraorbital approach, both approaching the anterior fossa anterolaterally, not anterior, but anterolaterally. We have the bifrontal approach, and we have the classic subfrontal approach reaching the midline. So we have the subfrontal approach, the lateral subfrontal approach, the bifrontal approach. The subfrontal approach is reaching the midline, is a classic approach, replaced in many cases by the lateral subfrontal approach. Why, you will see now. But I still use it in cases of big olfactory groove meningioma. I don't open bifrontal. I don't need to have bifrontal, and I'm totally satisfied with the unilateral subfrontal approach, even if the olfactory groove meningioma is very big. I can get it from one side. Why? Because the more you take of the tumor, it creates a space, and this will give you enough space to reach the other side. So the classic right subfrontal approach. This is the classic. You do the burr holes in the midline. Of course, there are less important approaches like the glabellar approach and things like that, but I'm talking about the most important approach. The subfrontal, classic subfrontal, reaching the midline. The lateral subfrontal approach or eyebrow approach. If you talk about the bone, it is lateral subfrontal. If you talk about the skin incision, it can be used by the eyebrow. So whatever you want, you can say it. The lateral subfrontal is actually the eyebrow. Maybe the eyebrow could be smaller, but the principle is the same. You go to the anterior fossa from lateral subfrontal. The most commonly used approach to reach the midline and middle fossa structure, like olfactory groove meningioma, tuberculum celli meningioma, prechiasmatic craniopharyngiomas. Why it is named lateral subfrontal? It is named after the bony frontal flap, and eyebrow after the skin incision. What are the advantages of the lateral subfrontal over the classic subfrontal? In most cases, we don't open the frontal sinus, so less incidence of infection and sinus repair. It doesn't injure the supratrochlear and supraorbital nerves, which are injured in the classic subfrontal approach, being medial in the frontal region, and less incidence to injure the olfactory nerve. So these are the advantages of the lateral subfrontal. And here, this is the bifrontal, of course, and the lateral subfrontal. You reach it by doing an incision, sutar incision extending to the other side, or from the eyebrow, as you wish. From the eyebrow, you have the lateral subfrontal. The most important thing here is that what is the height from inferior border to superior border of this approach? It is the height that allows the fully opened bipolar. You get your bipolar forceps, you leave it open, and it gives you the space of 3 centimeters, 4 centimeters, so that you can use your bipolar freely when you are coagulating meningioma or something like that. So it is in the lateral subfrontal region, can reach it by the eyebrow, or you can reach it by the suture incision to the superior temporal line if the eyebrow is thin or not well developed. And you have to have, this is very important, the height is that of an opened bipolar forceps, fully opened. Don't make it very narrow, you cannot enter your instruments. Again, the lateral subfrontal approach. Look here, the frontal sinus is away. Look here, the supratrochlear, supraorbital nerves are away. And of course, from inside, going from the lateral side, olfactory nerve is away. The bifrontal approach, it's no longer used like before, but it is designed to reach large midline tumors like olfactory groove meningiomas, and not frequently used now. This is the suture incision, and this is, you do the craniotomy bifrontally. Here, all this is the bifrontal approach. And the transsphenoidal approach and the extended transsphenoidal approach, you can reach the anterior fossa, yes, and the middle fossa, of course, and it is used for midline structures, pituitary adenoma, craniopharyngioma, tuberculum cellular meningioma, chordoma. Of course, all of them are in the middle fossa, but if it is extending to the anterior fossa, you can drill the anterior part, the planum sphenoidal, from below, so that I consider it part of the approaches to the anterior fossa. Because to reach a adenoma is easy to go to the floor of the cella, but craniopharyngioma, tuberculum cellular meningioma, and chordoma, maybe chordoma also, but tuberculum cellular and craniopharyngioma, you have to drill the planum sphenoidal, what we call extended transsphenoidal, anterior extended, reaching the anterior fossa. And it can be tailored to the site, reaching the clivus, the petrous, the middle, and the orbit. Of course, this is the view of the patient when you are doing the transsphenoidal or extended transsphenoidal, and the nose is in axis, the same axis as the surgeon. Elevation of the head to reduce sinus bleeding. And of course, you go with the endoscope, you can reach the anterior fossa, you can reach the middle fossa, you can reach the posterior fossa with the clivus. So this is the transsphenoidal or extended transsphenoidal is an approach you can put for anterior fossa, for middle fossa, and for posterior fossa lesions in the midline. Of course, you all know about it. There are a second group, is not the anterior fossa, but anterior and middle fossa. The pterional approach is the most important and common approach in neurosurgery. Professor Dolenz, Vinko Dolenz, used to say that there are three approaches to the brain: the pterional approach and its modifications, the transcallosal, and the posterior fossa. So we only have three approaches to the brain. It's not like that, but simplifying things: pterional, transcallosal, and posterior fossa. So one of them is very important. And many modifications are made, like classic pterional, mini pterional. Dolenz approach is a modification of the pterional, cranio-orbitozygomatic approach, and mini cranio-orbitozygomatic approach. All these are modifications of the pterional. Classic pterional approach, designed by Professor Yazergil, you know the classic, and you reach with your incision up to the midline, and you have your bone flap reaching the mid-pupillary line, and you have the keyhole, which is, as I used to say, below and behind the lower end of the superior temporal line. Superior temporal, it's not the pterion. As we said in craniometric points of the vault, the key point is not the pterion. Sorry. So this, you put your keyhole here, you extend it to the mid-pupillary line and you go down above the zygomatic arch. This is the classic Tyriona. It is exposing the anterior and the middle fossa from lateral. This is the classic Tyriona. It is temporal and lateral subfront. The mini-Tyrional approach, when you are not using the frontal region too much, if you want to reach the temporal and the frontal region and the sylvian fissure, you do the classic Tyrional. You reach it medially to the mid-pupillary line. If you don't need the frontal region, you need only the sylvian fissure and temporal lobe, like in aneurysms, like in some cases of gliomas, you can do the mini-Tyrional along the Tyrion, also the key point, and then along the superior temporal line, and you go down. You can tailor your flap according to the lesion. You need the frontal, you go to the mid-pupillary. Don't need the frontal, superior temporal line. Smaller and smaller as you wish according to localization of the lesion. So the difference between the Tyrional and the mini-Tyrional. Mini-Tyrional, superior temporal line. Tyrional, mid-pupillary line. Again, this is a mini-Tyrional approach. And Dolenz approach, some people or a lot of people are perplexed with what Professor Dolenz did. Actually, it is a classic Tyrional approach. You remove, with this approach, the lateral wall and the roof of the orbit, and the lateral wall before the roof to get space laterally, not to injure the periorbita of the roof. So we took the Tyrional approach, remove the lateral wall and the roof of the orbit, and we take the sphenoidal ridge till the end, the free edge of the anterior fossa, made of the lesser ring of the sphenoid. You go medially and you take the whole anterior clinoid extradurally, exposing the optic nerve extradurally, carotid artery in the carotid and anteromedial triangle or the clinoidal triangle extradurally, and the superior orbital fissure. So this is Dolenz approach, Tyrional, removing the walls of the orbit lateral and superior, the sphenoid ridge and the anterior clinoid medially, exposing the optic nerve, the carotid artery, and the superior orbital fissure, and it changes the steps between the anterior and middle fossa into one step. You know that the anterior fossa is shallower, and there is a step. The middle fossa is deeper than the anterior fossa, and the posterior fossa is deeper than the middle. So, to expose the cavernous sinus, you have to take this step between the anterior fossa and middle fossa. What is the step? It is the sphenoid ridge, it is the anterior clinoid, it is the roof of the orbit and the lateral wall. If those come down, you will find the cavernous sinus very superficial, became superficial because you took the bony umbrella of the anterior fossa so that you exposed a medial deep part of the middle fossa. This is the idea. And you take care, extradural decompression of the optic nerve might be risky. The Americans modified Dolenz approach, and when they wanted to do a Dolenz approach, they took out the sphenoid ridge and superior orbital fissure, but they left the most medial part of the clinoid, and you do it intradurally because there is risk of 5%, of course not in Dolenz hands. In Dolenz hands it was less than 1%, but other people, there is 5% incidence to injure the optic nerve if you take the clinoid extradurally. So better open the dura, see the optic nerve, and continue the approach by taking the anterior clinoid intradurally. So this is what I was telling you, the step between the anterior fossa and middle fossa. I want to go to the medial part of the middle fossa. You take this step, you take the sphenoid ridge, you take the anterior clinoid, you expose the carotid, you expose the superior orbital fissure, And you get this nice view. This is the left side. We saw it in the triangles. We take the anterior clinoid. You get the optic nerve, which is medial to the anterior clinoid. You get the extracranial carotid artery, clinoidal carotid artery, which is medial to the anterior clinoid. You deroof the orbit and the sphenoid ridge, so you see the superior orbital fissure. And you see the cavernous sinus becoming superficial. And you can see the proximal and the distal rings. So, Dolenz approach. Cranio-orbitozygomatic approach. The cranio-orbitozygomatic approach. They say they take the classic pterional approach, but they take with it the zygomatic bone and zygomatic arch. What is the use of this approach? This approach, the more you go down, the more you can see up. For it is an ideal approach for tumors in the suprasellar region, in the interpeduncular fossa. When I take all this bone, I can look up to the interpeduncular fossa. So when you approach the upper third of the clivus, the most ideal is the cranio-orbitozygomatic approach. And also, it is very useful approach if you have an intracranial and extracranial tumor like trigeminal schwannoma, and you want to get it from the intracranial cavernous sinus and the infratemporal fossa. And it is an excellent approach also for tumors extending between the infratemporal fossa and the middle fossa like angiofibromas. So, cranio-orbitozygomatic. You can do it in two pieces. You do the classic pterional, and then you remove the zygoma. Classic pterional, and then you remove the zygoma. We do the suture incision of the skin to go down as much as we can. And this is after removing and coming back again to things. So we took it here in two pieces. You can take it in two pieces, no problem. You take the pterional, then you have to cut the zygomatic bone here, and the cut at between the zygomatic bone and the maxilla, and cut the zygomatic arch. And here is cranio-orbitozygomatic. The mini cranio-orbitozygomatic, some people say, why should we take, in all cases, the arch of the zygomatic bone? If I want to go up and see the interpeduncular fossa, I don't need the infratemporal fossa, leave the zygomatic arch in place, and take the pterion with the upper border of the orbital rim, what we call the mini COZ. Some people call the mini COZ COZ. So you are perplexed. But it is called, this is the mini COZ. And here I left the zygomatic lateral orbital rim, I left the zygomatic bone, and I left the zygomatic arch. And I took a pterion, but with the upper border of the orbital rim and part of the lateral wall of the orbital rim. In this case, I can see up without problem. So whether you do the classic cranio-orbitozygomatic or you do the mini cranio-orbitozygomatic, it is actually a cranio-orbital. There is no zygomatic in it. So the mini cranio-orbitozygomatic is mainly cranio-orbital. Middle fossa approaches, anterior subtemporal approach, very important approach. If you want to do the Kawasi, is a part of the Kawasi. If you want to go in the temporal subtemporal region to reach the cavernous sinus or the floor of the middle fossa, this is, you can do a linear incision or you can do an interrogation mark incision. This is the incision for the posterior subtemporal. We're talking about the anterior subtemporal. So it is above the zygomatic arch and it is anterior. You go anterior to the ear pinna, anterior to the mastoid, under as low as possible at the zygomatic arch, and you elevate the dura extradurally or intradurally. This is the subtemporal, anterior subtemporal approach. And this is the space you can expose. The temporal lobe is here, and you are under the temporal lobe. Anterior subtemporal. The anterior subtemporal is the first step in the anterior petrosal. You go subtemporally, extradurally, but you have to drain a lot of CSF. The key for the extradural approach, Kawasi approach, could be a hell if you don't drain CSF. Subtemporal approach could be a hell if you don't drain CSF. How much? 15 to 20 cc's. How can I do it? You don't have to do a lumbar drain. You just do a lumbar puncture, evacuate 15 to 20 cc's of CSF before retracting the dura upward. And here, the right side. And here is the, as we said, Kawasi, if you remember, Kawasi triangle is not an actual triangle, but it is a rectangle, and it is medial to the greater superficial petrosal nerve. Lateral to it is Glasscock's, and this is in the middle fossa, and this is in the anterior medial petrous bone. The medial part, anterior petrous bone. The part that has no cochlea in it. The part that has some air in it. And we have here the trigeminal root, lateral to the trigeminal root, between the trigeminal ganglion root, between the superior petrosal sinus, and between the greater superficial petrosal nerve. And then you connect the hiatus of the nerve with the superior petrosal sinus. This is trapezoid. So the bone lateral to the trigeminal is thin, and you can take safely as much lateral as you can. When you stop laterally, you stop laterally when the bone gets thicker. As we said, when the cochlea can be jeopardized, as we said, it's a jewelry box. The box has a thick wall, but the medial part has some air. So you can enter from the middle fossa, the lateral aspect of the pons. This is the basilar artery, and the lateral aspect of the pons, or can extend it superiorly or posteriorly, and it is ideal. Kawasi. First, do subtemporal, anterior subtemporal, peel the dura, identify the great superficial petrosal nerve, go medial to the nerve, in the petrous part, lateral to the trigeminal, below the petrosal sinus, and you can close the petrosal sinus and open the tent here to get more space. So this is the tentorial hiatus. Actually, you can see here, and you can open the tent and see more laterally if you want. Again, we saw it before, greater superficial petrosal nerve, Glasscock's triangle, and Kawasi. You see here, the bone is very thin. It has nothing here. Very thin bone, some air inside, above the foramen lacerum. Carotid is here. You go laterally, you will find the cochlea. So what is your limit laterally when the bone gets thicker? And this is an example of a case that was operated by Kawasi approach. Actually, the tumor itself did the Kawasi job. It was a trigeminal schwannoma, one from the root and one from the cavernous, and we did subtemporal. You do subtemporal, and then you go in the medial part of the petrous bone. Sometimes the tumor is doing the job, like in here. And here, we can enter from here. This is the petrous bone, the medial petrous bone, and you can reach the lateral brainstem you can reach the ICA, part of the basilar artery, and you extend it laterally if you open the tent after coagulating superior petrosal sinus. Posterior subtemporal, as we said, the incision is from here and going behind the ear. Anterior subtemporal, I prefer to do the incision like that. Posterior subtemporal, I go from the mid-zygomatic point up and down like that, the bone flap. And you always remember that the supramastoid crest is a very important landmark. Above the supramastoid crest is middle fossa, below is posterior fossa. So you have to keep your burr hole. If you want to expose posterior subtemporal, you have to keep the burr hole above the supramastoid crest. What if it is not that clear? The supramastoid crest is the same line with the upper border of the zygomatic arch. So you have no excuse. Zygomatic arch, upper border, posteriorly, it's the level of this. Burr hole above the supramastoid crest and burr hole mid-zygomatic. And for the posterior subtemporal, the most dangerous and most terrifying is the vein of Labbé. Again, because if you cannot, what is the limit of posterior subtemporal elevation is the vein of Labbé. If you do too much elevation, you can injure the vein of Labbé, and you can injure the entrance of the vein of Labbé into the transverse sinus, and this is very dangerous because it is incompatible with life, especially on the left side. But actually, it is dangerous from both sides if you want. And to go laterally, we are talking still about the approaches to the middle fossa. You can go endoscopic approach, and we call the transpterygoid approach to the middle fossa. Not to be perplexed, I will tell you just one thing. When you go transsphenoidal, you go to the pituitary, you go medial to the middle turbinate. But here, you go lateral to the middle turbinate with an ENT surgeon. So you get what we call the bullus isthmoidalis hiatus semilunaris, and then you get this view of the maxillary sinus. And of course, the roof of the maxillary sinus is the floor of the orbit. So you can reach the orbit, you can reach the cavernous sinus, you can reach the infratemporal fossa. So one of the approaches to the middle fossa is the transpterygoid approach. Look here, this is the between the medial and lateral pterygoid plates. How can you identify the medial pterygoid? It is the lateral boundary of the choani. What is the choani? It is the posterior nasal opening. And at the root between the medial pterygoid plate, lateral pterygoid plate, the point of junction, you have the Vidian nerve. What is the Vidian nerve? The union of the greater superficial petrosal nerve and the deep petrosal nerve. And in that, so you can still reach the middle fossa from below if you take what is lateral to the middle turbinate. What is medial to the middle turbinate, you reach the pituitary, you reach the clivus. What is lateral, you reach the maxillary sinus, you open it, you reach the orbit, you reach the lateral cavernous sinus if you want. So, when here is the pituitary, and this is the internal carotid artery, but if you go laterally, you can reach Meckel's cave, you can reach the whole cavernous sinus, you can reach the middle fossa. Here is V2, here is V3 in the foramen ovale, and this is the foramen rotundum. Then we talk about, we finished the anterior fossa, anterior middle, posterior fossa. This is what we are going to talk about. The pre-sigmoid subtemporal approach, the posterior petrosal approach, and you go like the posterior subtemporal, but you go also doing the Trotman's triangle with it. So you take subtemporal and you do Trotman's triangle, and you can extend it to reach the retrosigmoid part to expose the posterior fossa also. So this is the posterior petrosal approach. You can do it in one flap, you can do it in two flaps, and then look, I am subtemporal here, I am presigmoid here, and as we said, what is between anterior to the sigmoid and inferior to the superior petrosal and medial to the semicircular canal is Trotman's triangle. And you expose part posterior so that you can get the sigmoid posterior. What is the advantage? You minimize brain retraction. You go for lateral brainstem lesions in a shorter direction. If you go retro sigmoid, cerebropontine angle, you are in an oblique direction. And if you go from here to reach here, this is a long distance. So this is an oblique, long view. This is a direct, short view, the subtemporal approach, and you sacrifice the superior petrosal sinus, which is the free edge of the tent, and you cut the tent and you connect the anterior fossa with the posterior fossa. And if the space is not enough to expose the posterior fossa, you have to be exposing part. You have to expose part of the posterior to the sigmoid, and you have to go down to the jugular bulb so that you can displace the sigmoid posteriorly. One trick, you should leave the sigmoid skeletonized. What do you mean skeletonized? Covered by a thin layer of bone, because if you retract on the sigmoid and it's not skeletonized, you can injure the sigmoid and result in post-operative sigmoid sinus thrombosis, which could be hazardous. It's a disaster. So many tricks, I can't say everything, but this is a junction between the middle and posterior fossa is the pre-sigmoid subtemporal approach. Posterior fossa approaches, of course, you all know the classic approach when you reach medulloblastomas, ependymomas in the midline, and telovelar after that, and you remove the bone flap according to what you want. And this is, you do a craniotomy or craniectomy as you wish, but of course craniotomy is preferable. And you can reach from here the supracerebellar infratentorial approach to the pineal region and to the trigeminal root, and this is the view. And if you go from below, this is the tent. You should leave, you should expose the dura about 2 centimeters above the transverse sinus. You can have, you can hitch stitching the tentorium so that you can get retracted above, you get more space. And here you can see the precentral cerebellar vein guiding you to the great cerebral vein of Galen, and you see the basal veins of Rosenthal and the medial occipital veins. So this is the pineal region. Supracerebellar infratentorial lateral approach is the same, but you don't go in the midline. What is the advantage? The midline is very high, but the lateral is lower. So you can go from lateral to the pineal region easy. You can reach the quadrigeminal plate, you can reach the posterior midbrain, and you take the quadrangular lobule and you reach the pontomedullary, the midbrain pontomesencephalic junction, what we call the infratrochlear approach. It's not important, but you know that there is midline supracerebellar infratentorial and lateral supracerebellar infratentorial. And this is a nice view you can get from below. And this is the posterior edge of the tent. This is the posterior incisural space. And you see the veins and the pineal region and everything you want from here. Quadrigeminal plate. Paramedian approaches, for instance, cerebellar astrocytoma. or a hemangioblastoma inside the cerebellum. Retrosigmoid approach, of course you all know about it, the very famous approach. You go 1 centimeter behind the mastoid and you extend linear or curvilinear or S, whatever you want, incision, and you stop at the mastoid tip and you go up to reach the cerebellopontine angle, and you go with the bone flap as superior as the transverse and as lateral as the sigmoid. Here, and you open the dura below the transverse and medial to the sigmoid. So this is retrosigmoid. The first one was pre-sigmoid. And the far lateral approach, it's a simple approach. If you do it far lateral without taking out the occipital condyle, it is called simple far lateral. If you take the part of the condyle, the posteromedial part of the condyle, it is called transcondylar approach. And how far you can take from the most posteromedial part up to an emissary vein. So you can do the incision this way. You want to take the lateral suboccipital region to expose the lateral cerebellum. You take part of the arch of the atlas, the bony arch of the atlas, to reach the craniocervical junction from laterally, which is ideal for foramen magnum meningiomas or tumors anterior to the brainstem and the lower clivus. From upper clivus and interpeduncular fossa cranio-orbitozygomata. Mid clivus petrosa. Lower clivus far lateral. Where is the lower clivus? Foramen magnum to the lower cranial nerves. Mid clivus, lower cranial nerves 7 and 8. Upper clivus from 7 and 8 to the dorsum cell. So again, this is the incision you take for the far lateral approach if you want to do it. I myself prefer to approach foramen magnum meningiomas by extending the midline approach laterally. I don't like to do an incision here with the vertebral, but you can do it. It is a nice approach. Look to the extent of bone you remove up to the transverse sinus and in the craniocervical junction, and you take part of the arch of the atlas should be taken, and then would you take part of the occipital condyle or not depends if you want to go more laterally because the tumor is more anterior, so you take part of the occipital condyle. Again, this is the extent of the bone you can remove. The inferior part of the plate of the occipital bone laterally and part of the occipital condyle. If you take the posteromedial, look, this is posterior and this is the mid. Posteromedial part laterally, you get an emissary vein, you should stop. If you stop at this point, you can, because this will prevent the dura from going lateral. If you stop at this point, it is a stable joint. But if you go more to take the occipital condyle totally, you have to end by fixing the craniocervical junction. Look here, we took our incision. Sometimes people do it this way, sometimes they do it as we saw before, behind the ear, and then you open the dura, and then you reach here the sigmoid sinus, and then you expose. If you take the cerebellum medially or above, you can see a very nice view of the craniocervical junction, lower cranial nerves 7 and 8. You can reach up till 5 if you want. And of course, this is the cerebellum taken up. This is the pica, and this is the lower cranial nerves. It's 8, this is 9, and this is 9, 10, and 11. This is the 6th nerve, 7 and 8. And you get this nice view of the craniovertebral junction. Look here, to take the dura more laterally, you have to take part of the occipital condyle. If you want to go more laterally, if the tumor is more anterior. The only obstacle that prevents the dura of going more laterally is the occipital condyle. You can take part, and in this case it's not a simple far lateral, it is transcondylar far lateral. Thank you very much. I hope I did my best to summarize and give you some tricks about the skull base approaches, but as you know, it's a very, very long subject, and maybe you can have a chance to discuss each approach later on with more details. Thank you very much for your attention, and by this we end all the skull, and we'll be in the next lecture going down to the spine, cervical fractures, dorsolumbar fractures, sacral and sacral fractures, and I think this will end our series of applied neuroanatomy. Thank you very much for your attention. Until we meet again, take care.